Hey everybody, I'm Maggie, and this is another episode of SRH Access Facebook Live. Today I'm here with Dr. Anthony Bricchio, and we're going to talk about pediatric foot disorders. How's it going?
Excellent. How are you doing, all right?
Great, we're happy to have you
Yeah,
here.
it's fun to be here.
I
Thanks
know
for
you're
having me.
excited.
Yeah,
Let's get
very,
this
very
going.
excited.
So, foot disorders. Let's talk about flat feet. What can we know about those?
So fundamentally what a flat foot is a foot that has an arch that's a little lower than normal. And this can generate a lot of concern among parents. It can generate a lot of concern about from pediatricians. And it's something we see very commonly at Scottish Rite.
Okay, and then the difference between rigid and flexible flat foot.
That is an excellent question, and it's really kind of the first thing we need to determine in assessing any child who comes in our clinic with a flat foot deformity is the flexibility of the deformity itself. A rigid flat foot is a foot that's flat and stays flat. It can't be passively corrected. It doesn't change during ambulation or firing of the muscles. A flexible flat foot, which is really the more common type of flat foot deformity, sometimes called a hypermobile flat foot, is a foot where there's complete motion maintained between the joints of the hindfoot and the midfoot. That foot we can passively correct into a more normal position. If a child isn't standing on the foot or sitting on a bed or something along those lines, their arch will reconstitute on its own when gravity is removed. And if they are able to fire the muscles that cross the ankle and attach to the hindfoot and dynamically mobilize the joints of the foot, that arch will typically reconstitute on its own as well, say with standing on their toes or something along those lines. Hypermobile flat feet are very common. That's the kind of run-of-the-mill variety of flat feet that a lot of folks in the world have and usually never have problems from. A rigid flat foot deformity is typically indicative of some form of pathology, either abnormal structure or bony anatomy, or possibly a neuromuscular condition.
Okay, and before we move any further, live questions, we're taking them, post them below, and we'll have Dr. Bricchio answer them live, which is pretty cool. So what about, are these kids born with flat feet, or is it something they gradually get? Is it genetic?
Yeah, actually, almost all of us are born with flat feet. We don't typically develop arches in our feet until we learn to kind of fire the muscles that cross the ankle joint and insert around the foot. So flat feet are extremely common, bordering on ubiquitous in infants, very, very common in young children and toddlers who just begin to walk, and fairly common in the adult population as well.
So then how is it diagnosed for if a parent is kind of concerned about maybe their child's foot, they come into Scottish Rite Hospital, what should they be looking for?
What we look for, it's a clinical diagnosis, and it's all based on physical examination. What we typically do is assess the child in a standing position, and we look at the toes from the front, and oftentimes if a foot is flat, there'll be a little outward rotation of through the middle of the foot that'll make the toes point a little externally or towards the outside. From the side, you can see that the arch is collapsed, and depending on the severity of the deformity, a lot of these children will actually weight bear on the inner border of their foot rather than having that elevated up, such as in a child that has a normal arch. Typically the weight bearing is more distributed on the front and back of the foot. And then from behind, the heel bone looks like it's tilted to the outside. And of course these vary in severity depending on the severity of the flat foot deformity. But once we see that constellation of findings on an exam, that's how we diagnose the flat foot deformity, and the rest of the workup is basically determining its flexibility and then talking to the patient to figure out how symptomatic they are as a result of it.
Right, and depending on like how active they are and age of where they are in their life.
The vast majority of children with flat feet, especially the youngest children we see, certainly those prior to adolescence, almost never have any pain or discomfort or certainly any functional limitations as a result of this. What we look for in the older kids, those kids typically come because a parent is concerned, and that makes perfect sense, or a pediatrician is concerned. They just want reassurance that this is on the spectrum of normal, which it often is if it's flexible. And oftentimes they want to know, is there anything we can do to kind of help change the shape of the foot or prevent problems down the line. Also all reasonable questions. Typically older kids will come to us if they are symptomatic. And it's
Okay.
important to understand that only a very, very small portion of the population who has club feet, even if they're quite severe, even if they're very active in athletics or other recreational endeavors, have symptoms due to their flat feet. Most folks with flat feet are never bothered by them whatsoever.
That's good to know.
Yeah.
So, I mean, I guess that kind of goes into long term. I mean, what are the possible extremes of long term effects of the flat feet?
Yeah. So, assuming we're talking about the kind of run-of-the-mill flexible flat foot deformity, the hypermobility, the hypermobile flat foot, what we look for as far as spectrums of severity, and we're talking about those children who unfortunately are bothered by it,
Right.
is we question them about their pain and where the location of pain is. Pain, when they are symptomatic, pain is typically along the medial arch or medial border of the foot because they're putting most of their weight there during stance phase, as opposed to that weight being evenly distributed between the front and the back of the foot. A lot of children will even develop callosities along the inner border of the foot, and if the skin's changing, that's a good sign to us as clinicians, kind of alerting us to the fact that there really is some excessive force across that part of the foot, and it doesn't surprise me when a child's telling me he has pain or discomfort if there's a callus there. And a certain subset of children, because as I mentioned, the heel bone, which normally is fairly straight when we're standing, is tilted to the outside. A certain portion of children will actually have pain on the lateral side of their ankle or the outside of their ankle because that heel bone almost abuts or impinges on the lateral ankle bone, what we call the lateral malleolus. Looking from behind, this would be the lateral malleolus, and this would be the heel bone in a normally aligned foot. And in a flat foot, this heel bone could be splayed way to the outside where it could abut or impinge on the soft tissues laterally.
So, what about treatment? Surgical, non-surgical? What are the options for flat feet?
Sure. So if a child is completely asymptomatic and simply have a flat foot, we advocate no treatment whatsoever, and we just spend a lot of time educating parents that this is well on the spectrum normal. In the vast majority of cases, it will never be bothersome, and hopefully we alleviate some of their concerns just through education. In a hypermobile, flexible flat foot, there's nothing that can be done to make that foot assume a normal arch, shy of a surgical procedure, which is unindicated. So things like special exercises, wearing special shoes, investing in off-the-shelf inserts or other devices that are reported to help kind of create an arch is all unnecessary.
Okay.
Anything that's put in a shoe or around the foot is simply used to control the position of the foot in space.
Okay.
It will not lead to arch restoration.
So, is that something we can look into with these?
Sure. Now these are the typical types of inserts that we'll make here at Scottish Rite for children who have symptomatic flat feet that are flexible. And what these are a variety of different orthotics. This is a hard plastic orthotic called a UCBL, University of California Berkeley Labs orthotic. And this is a very stiff, rigid orthotic that actually, looking at it from the side, drives the arch up and tilts the heel out of that externally rotated or valgus position. I actually, this is something that's been used historically, but I find most of my patients really don't enjoy this prosthesis because it's firm and rigid, and if they've already got a foot that's a little uncomfortable, putting something hard in their shoe usually isn't something they enjoy very much. I tend to use something more along the lines of these soft cork orthotics, or even something without much of a backing on the bottom. And my goal in a symptomatic flexible flat foot is really to kind of post or put a wedge under the inner aspect of the heel, again looking at our model, so that when the child takes a step down, rather than that heel turning way to the outside and allowing the foot to roll flat, that foot will almost be forced to roll to the outside of the foot and keep that arch up off the ground. And I find that works really well. It takes a lot of pressure off of the instep of the foot. And again, in the vast majority of our patients, I'd say 95%, they get significant relief, at least for some time, using those types of orthotics.
That's good to know.
Now, obviously, those don't work for a rigid type of deformity,
Right.
but they're invaluable if the deformity is flexible.
Okay. So with flat feet, is there anything where another type of foot condition can kind of come from that? You know, if a kid is walking and they're compensating on one foot than the other, you know, like a tarsal coalition or something like that.
Oh, something along. Okay, so what a tarsal coalition
Yeah.
is a tarsal coalition is an abnormal bony connection
Okay.
between two bones in the foot, typically in the hind foot, that should have free motion between the two of them.
Okay.
Looks like we lost our.
I know.
I can show you an example
Yeah,
if
you
you're
can log
able
back
to
in.
log back.
There we go.
There we go. So here's an X-ray actually of a tarsal coalition. You getting this on the? We seeing this at home? Beautiful. So the two bones involved here is the navicular bone, and this is kind of the biggest bone that traverses across the middle of the foot. And this bridge right here between that navicular and the heel bone here is not normal. There's supposed to be free space in there. And with that free space or normal joint that's supposed to be there, that heel should be able to swing back and forth and in and out, and that motion's really critical to managing uneven terrain, cutting in sports, going climbing, and anything basically that
Right.
involves cutting or side-to-side motion. But with this thick, dense, bony bridge between the two of them, it restricts motion in the back of the foot by locking the heel bone in position. Now, often the position is locked in is an everted position, which drives a flat foot deformity. So
Okay.
a flat foot doesn't create a tarsal coalition.
Okay.
A tarsal coalition is usually what we're looking for when we're working up a rigid flat foot deformity, and it's
Okay.
probably the most common cause of a child who comes in and their foot's flat, but the arch doesn't reconstitute when they sit. It doesn't reconstitute when they stand up on their toes. And that's when we'll use radiographic imaging like this to kind of look into the bones of the foot and see if there's something like this there.
Is there a common age that this comes about?
Well, the thing about this is it's been present the child's whole life. So the
Okay.
coalition is always there. Now, some folks think that it starts out as a fibrous or more soft tissue type of
Right.
connection and ossifies over time. But the truth of the matter is, the reason this bridge is there is probably a failure of programmed cell death, what we call apoptosis, way back before the child was ever born, when they were still in utero.
Okay.
And then the cartilaginous bar ossifies over time. So the coalition in these kids, we assume, has always been there, and it remains asymptomatic for most of the child's early life. We frequently see symptoms from this sometime around early to mid to late adolescence.
Okay.
In children who are symptomatic, there's a whole lot of us out there who have these coalitions who don't know it and do just
It
fine
doesn't
with our
bother
feet, and we never see them in our clinic.
Cool. What about, so research, that's a really big part of, you know, these foot disorders. So what are we doing at the hospital?
Yeah, so we've got our an ongoing foot and ankle deformity registry at Scottish Rite that we're really proud of. All of our patients who come in with a variety of different foot deformities, ranging from flat feet, be they flexible or rigid, to cavus deformities, which are feet to high arches, to various deformities caused by tarsal coalitions. If they're willing to do so, are enrolled in a registry, and we collect data with regards to their pain. We actually do very detailed pressure measurements on the bottom of their foot called a pediobarograph.
Okay.
We run them through our motion analysis lab, and I think your session last week
Yeah.
was in that lab. So we actually get a sense of how their ankle mechanics work and how much pressure they're able to generate on their feet with running, walking, and jumping activities. And then we kind of look at the interventions that are performed. Conservative interventions like orthotics, no intervention like observation, and then of course surgical interventions, with the hope that one day we'll be able to say, look at this broad spectrum of a diagnosis, flexible flat feet, for example, and maybe predict the kids who are going to become symptomatic later in life. Maybe predict the kids who are going to do great with
Right.
just an orthotic, and maybe predict the kids who are going to be failures with any type of conservative treatment, in which case we might be able to recommend surgery at an earlier age than we do now.
Yeah. Wow, that's really great. And I know it's ongoing. And,
Yes,
you
and
know,
it's-
what we're doing now will affect treatment for years to come. That's really
Correct.
cool.
Yes, ma'am.
So we actually have a live question.
Oh, okay,
So
great.
you're popular. That's cool.
Is that rare?
Yeah, I mean, hey.
Did
So-
Dr. Wimberly get any live questions last week?
He didn't, but that's okay.
Yes.
So, a parent wants to know, will flat feet affect a child's ability to play sports normally?
Absolutely not. Again, the presence of a flat foot in the absence of any symptoms means very little with regard to functional capabilities. A lot of children who have more severe flat feet will have a little bit of contracture and tightness of the heel cord, the Achilles tendon, the big tendon on the back of the ankle. But some gait analysis studies have shown that they can still generate equivalent forces compared to other kids, again, with running and jumping activities. There's been some really interesting research in the military population. And for years, people, and still do, come in and say, well, my child's got flat feet, but he wants to go be a Navy SEAL or an Army Ranger, and we're afraid he's not going to get in. Well, the truth of the matter is flat feet do not keep you out of the military, and in studying Marine recruits and Special Forces folks in the military, it was found that they performed no differently than people without flat feet, and had no higher incidence of pain or complaints with regards to their feet during very intense training regimens, as well as during active duty deployment. So no, I wouldn't expect the presence of a flat foot deformity to affect your child's ability to play any sports whatsoever. Occasionally, if the flat foot is severe, it can be a little more difficult to find the right type of athletic shoe, especially soccer cleats. Ice skates are another one because they tend to be very narrow, and a flat foot tends to rest in a little bit of a wider position. And if there's difficulty finding appropriate shoe wear, occasionally a very soft insert can help with that. But if the deformity is flexible, it's actually pretty rare to not be able to find some shoe that the foot fits into well and that the child's comfortable in.
Great information. Thank you so much for that live question. I think this kind of is wrapping up our session today.
Oh, awesome. Okay.
That was really fun. Thank you for joining us today. And we will be live next week, next Wednesday at 1:30 when we're talking about concussions. So make sure you tune in. Thank you.